Hello, my name is Jason Wilson. I'm excited to talk to you today a little bit about HIV testing in the emergency department and specifically about a problem that we've seen arise with testing in the emergency department that perhaps puts providers in a difficult position with interpreting test results and also maybe limiting our ability to scale up ED-based HIV screening. And specifically, that's what to do with what we call an equivocal test result during the emergency department clinical encounter. Essentially, this bucket of patients that have what we call an equivocal results might either be a very serious patient who is acutely converting in front of us with HIV, or might actually just be a false positive patient who perhaps doesn't really have HIV at all, but is for some reason popping up with a reactive screening test. And so what we mean by this is on a fourth generation serum test, the antibody antigen screen reacting, but then on the confirmatory test, the antibody test being negative, and then having to wait for the RNA viral load to return to differentiate these two patients. So again, in the emergency department, these two patients essentially have the same laboratory signature. They look identical. They both have an antibody antigen screen that is reactive. They both have an antibody that is negative, but they're two very different patient groups. One might have immunodeficiency or immune problems like lupus that are causing the patient to react positively. But the other group has new HIV with a high viral load and is high risk for transmission. And also we have a chance to potentially engage that patient to get them linked to care while they're in the emergency department. And we know the quicker and sooner we make that engagement, the more likely it is that patient will enter and retain care. So let's talk a little about what we mean by equivocal results and what that looks like and what we think helps us differentiate those two patient groups, since most of us won't have an RNA result back during the emergency department encounter, at least right now, given the current CDC algorithm and the currently available technology. So again, an equivocal results, we're lumping into two different types of patients that are very different clinically. So laboratory similar, clinically very different. Acute positives, so HIV antibody antigen positive, antibody negative, but you detect RNA on the when you test for the viral load. Then the false positives, you find basically some reason that patient had antibody antigen screen reactive because they've got P24 antigen for some reason. However, on further testing, both the antibody is negative, but also the RNA is not detectable either. So they're actually false positives. How do we know the difference of those two patients in front of us in the ED? From the laboratory testing, we actually probably don't, but clinically we might have some clues. And then as time moves forward, perhaps the algorithm changes a bit, or perhaps technology catches up to where we are acutely. So right now, I think the problem most of us face is that we don't have a RNA test that comes back in a short period of time. Most of us probably wait 48, 72 or more hours for an HIV RNA PCR, which really, if you look at things in context, this is a little surprising, given that many of our sites set up COVID tests in a pretty quick amount of time using HIV, using RNA, and there's a number of other disease states where we use RNA PCR testing, but not with HIV routinely. So in this study, we really broke down the false positives and acute positives in that equivocal bucket, and we looked at their clinical characteristics to ask if there's anything clinical about those patients that might help us out. We've been doing this for a while now, over 5 years. We've tested 64,000 people, over 64,000 people, over 1,200 patients a month using fourth generation serum screening. And that's about 22% of all of our ED patients get screened for HIV. Of those 64,000 patients, 60,102 were negative, but 856 of those patients had antibody antigen reactivity. And they had antibody tested after that. So of those, 688 of them were easy. 688 of the 856 have antibody and antigen that are both positive. Those are easy bucket. You put those in the bucket of positive HIV. But a pretty large percentage of those patients, of those 856, 110 were actually indeterminate. So almost 20% of those patients had a equivocal laboratory signature, meaning that at the time of the ED encounter, we couldn't really tell the difference between whether those patients were false positives or, again, the much more serious acutely positive patient. And not to diminish the seriousness of a false positive either, because telling a patient they might have HIV and having to wait 3 days is not without some turmoil of its own. So of these 110 indeterminate patients, these equivocals, 75 became false positives. They had no RNA detectable, but 30 were acutes. So for purposes of this paper, let's drill down into this just a little bit and see if there was anything different clinically about these two groups of patients that could help us at bedside to sort of predict the probability as to whether the patient was an acute positive or a false positive. But keep in mind that overall, about 3.5% of all of our positives were acute positives, and about 9% of all of our positives were false positives. So a pretty large percentage overall, actually, and 20% had an equivocal laboratory signature, making it difficult for even advocates to promote scaling up ED-based screening to community sites and to other EDs until we sort of solve this algorithmic and technological problem. If we look at the data clinically, we see that there are some differences in these two patient groups. Patients that were more likely to be false positive were more likely to be married and have heterosexual sex partners. Patients that were more likely to be acute positives were more likely to have multiple sex partners, use IV drugs, and to be single as well. Not quite statistically significant, but those patients were also more likely to be homeless or incarcerated also. So overall, we know now that 20% of the patients that we screen for HIV in the ED have an equivocal laboratory signature. It's 1 out of 5 of every positive patient or every reactive patient, making that very difficult for an ED doctor to have a conversation with the patient at bedside. Some clinical information can help us probabilistically guess whether that's going to be an acute positive or a false positive, but because there's some reason that P24 antigen is popping up, but we need some more information, and what we probably need eventually is a rapid turnaround time RNA PCR test for those patients who have a indeterminate signature in the ED to get that information more quickly. So I appreciate this time you gave for the short presentation. This is ongoing work at USF Tampa General, and hopefully it helped. Here's our references. This is part of the FOCUS program, which is a Gilead-based funded program to promote HIV screening and linkage in the community. Thank you.